Hey, what's up everybody? Dr. Shawhead here and welcome to the first video in the Periodontics series, Periodontal Anatomy. And we're going to start with a review of gingival anatomy. It's important to be able to identify what the gingival anatomic landmarks are in periodontics. Clinically, the gingiva, which is made up of this coral pink keratinized tissue, can be differentiated from the red non-keratinized tissue or mucosa. This is separated by a visible mucogingival junction, or MGJ as some of you may call it. The free gingival groove refers to the shallow depression that presents just apical to the free gingival surface. In a healthy state, the free gingiva hugs the tooth tightly. In a diseased state, the gingiva is pretty friable and it can even be recessed. You can see a good example of localized recession on tooth number 24 here. Typically, a single area of recession is caused by a high frenal attachment or trauma. Intraoral piercings are pretty infamous for this as well. Now, between the free gingival groove and the mucogingival junction lies the attached gingiva. This is the portion of keratinized gingiva that is firmly bound or attached to the underlying alveolar bone. It plays an important role in withstanding the mechanical forces of chewing and toothbrushing, and in providing stability to the gingival margin. Adequate width of attached gingiva is often considered very important for maintaining periodontal health, especially around restorations and implants. Alright, now let's discuss our clinical examination of the gingiva, which I like to describe by the 3 C's. The first C is color. Now, healthy gums are coral pink, but in disease they become more red or erythematous from increased blood flow, often due to irritation by bacteria. The second C is contour. Healthy gums are scalloped with what's called a knife edge contour. So here, this inner dental papilla, if we were to do a cross section of a knife, this is what it would look like. It would be the scalloped knife edge contour. Now, in a disease state, they can become edematous, which is to say that they'll swell and become puffy. The interdental papilla loses its knife-like angle. The third C is consistency. Healthy gums are consistent in texture. However, in disease, they can be softer due to edema or even stiffer due to fibrosis. This friable diseased gingiva bleeds extremely easily. Alright, now let's look at the components of the periodontium. So the periodontium is defined as the supporting structures of a tooth. The periodontium consists of the gingiva, the cementum, the periodontal ligament or PDL, and the alveolar bone. Now there are 2 important high yield points to keep in mind here. Firstly, the PDL consists of type 1 and type 3 collagen fibers, with the majority being type 1 bone fibers. And second, the PDL attaches to the cementum and alveolar bone via collagenous fibers known as Sharpie's fibers. Now, not to get confused here, there are many different PDL fibers which we will actually go over in this video, but the ends of those fibers that connect to the tooth or the bone are known as Sharpie's fibers. So, in a way, Sharpie's fibers aren't a type of fiber per se. That's just what we call the ends of the principal PDL fibers, which we'll talk about very soon. Now let's take a closer look at some of the gingival fibers we have to be familiar with. There are several different types of gingival fiber groups, all based on their orientation and attachment sites. First, we got circumferential fibers, which encircle the tooth in a ring-like fashion, maintaining the contour and positioning of the free gingiva. Next, we have the dentogingival fibers, which extend from the cementum into the gingiva, contributing to the attachment and support of the gingival tissue. The dentoperiosteal fibers originate from the cementum. They run over the alveolar crest and insert into the periosteum of the alveolar bone, reinforcing the connection between tooth and bone. And the alveologingival fibers arise from the alveolar crest and project into the free and attached gingiva, helping to stabilize the gingiva against the tooth. Now, there's one more group you gotta remember, but we can't easily see it from this perspective because it's actually located between 2 teeth. So let's switch gears and look at the gingival groups from a buccal perspective. And just for a quick review, we'll go over some of the ones that I just talked about as well. So we have the circumferential fibers, the dentogingival fibers, and the alveologingival fibers on the left. We also talked about the dentoalveolar fibers, but those guys aren't shown here. So the last gingival fiber group I want to mention is none other than the transeptal fibers, which span from the cementum of one tooth to the cementum of an adjacent tooth. Now, here's a hygiene board exam pro tip for you guys. An easy way to remember principal fibers is with the acronym DAT-CT. Every other fiber group is secondary if it's not in DAT-CT. Definitely want to commit that to memory. Alright, now let's talk about the principal fiber bundles of the periodontal ligament, which play a vital role in anchoring the tooth to the alveolar bone, allowing for slight movement while withstanding masticatory forces. Now here's a quick pop quiz. The ends of these collagenous PDL fibers have a special name. And if you were paying attention earlier, you'll know that they are called Sharpie's fibers. They're the parts that are actually embedded into the cementum and alveolar bone. Okay, onto the fibers themselves. First, we have the alveolar crest fibers, which extend from the cementum just below the cemento-enamel junction to the alveolar crest, and they function to resist tilting and horizontal forces. Horizontal fibers run directly from the cementum to the alveolar bone and similarly help counteract tilting and horizontal forces. Next, we have oblique fibers, the most numerous of the PDL fibers, and these run diagonally from the alveolar bone to the cementum, and they're crucial in resisting intrusive or vertical forces, such as those generated during chewing. Apical fibers are located at the apex of the tooth and extend to the base of the socket. They serve to resist extrusive forces and prevent the tooth from being pulled out. Finally, intraradicular fibers are only found between the roots of multi-rooted teeth, and they help stabilize the tooth by maintaining root position. The next important concept you should know is biologic width, which now has a more fancy technical word, the supracrestal tissue attachment. And I kind of like the new name because it's very descriptive. Because the biologic width is the distance between the junctional epithelial and connective tissue attachments, both of which are above the alveolar crest. So let's break this down. The junctional epithelium starts at the base of the sulcus down to where the connective tissue attachment begins, close to the CJ. This distance is typically 1 millimeter. The connective tissue attachment starts from the bottom of the junctional epithelial connection down to the level of the alveolar crest, and this distance is also about 1 millimeter. Together, both of these attachments create the supracrestal tissue attachment, which, you guessed it, should measure about 2 millimeters. And that's really it, guys, for periodontal anatomy. Let's reinforce everything we just learned with a practice problem. Which is the most likely etiology of localized recession of the mandibular central incisors? Pause the video if you need some time to gather your thoughts, but the answer is C, a high labial frenum. If the recession is localized to the mandibular central incisors, this points to a local factor. A high labial frenum is the most likely cause, as the mandibular labial frenum is located between the mandibular central incisors, and this is a very common anatomic characteristic that can cause recession. And with that, we are done, guys. Here's a quick list of some of the topics I discussed in this video. Thanks for watching, and see you next time.